Today I'm presenting on the difference that technology is making in radiation therapy at the Northern Sydney Cancer Centre and the improvements expected in patient care as a result of its implementation. Radiation therapy is a treatment option that for a number of cancers leads to superior outcomes in terms of survival, local control and toxicity profiles. Currently, the utilisation rate for radiation therapy is approximately 38%, but the most recent review by Barton et al. Has found that radiation therapy alone, or in combination with chemotherapy or brachytherapy, is the treatment of choice for about 48.3% of notifiable cancers. I've been part of the radiation therapy community for the last 40 years, working both clinically and as a radiation therapist, and in education and research, and during this time the changes and development in technology have been incredible. Most recently, the more precise targeting of treatment sites has been possible by the advances in automation software and better quality image guidance hardware and software that has increased the ability to develop complex treatment techniques. So as you can see in this photo, the amount of technology in a room now compared to what it was even 5 or 10 years ago has really increased. Some of these technological advances have led to more time spent with technology outside the treatment room, checking the precise targeting of the treatment site. We are expecting, however, that some of the automation software now available or soon to be available will allow us to reclaim quality time with patients, perhaps not while they're in the treatment room, but in our interactions with them as part of their ongoing care. These time savings will open up opportunities for radiation therapists to play a role in a patient's initial consultation, treatment reviews, and patient follow-up. This automation technology will also allow more individualised daily treatment adaptation and linking this data to an analysis of long-term outcomes, which should result in improvements for patients in terms of survivorship, reduced toxicity, and decreased recurrence rates. The Northern Sydney Cancer Centre has spent the last 10 years aligning best practice with developing consistent and quality treatment planning data that has enabled us to embrace knowledge-based planning with the aim of achieving consistency, improved plan quality, and efficiency within the department. Knowledge-based planning, and more specifically for NSCC, the Variant Product Rapid Plan, uses our existing dose optimisation planning data to train and create models for specific treatment sites. In other words, to train models to optimise dose to a treatment site by maximising a homogeneous dose to the tumour volume while minimising dose to normal tissue structures. So once a model is created, it then requires validation, and this is done by using the model to plan previously treated patient cases and comparing their original dose plan with the plan created from using the model. If the model needs improving, it's edited to produce better quality plans, with high quality plans being fed back into the model to improve it further. Once a model is validated, it can then be used for new patients. Having created models for multiple treatment sites, Rapid Plan at NSCC became clinical in September 2017. Up to this point, about 24 models are available which are capable of producing clinically acceptable dose plans for 50% of our patients. With the techniques currently used for the treatment of palliative cases and breast cancer cases, which make up approximately the other 50% of our patient load, no models are yet available. Understanding the potential benefit of utilising more complex planning techniques for breast cancer or palliative radiation treatment is an area of current research. Using more complex techniques for these cases are likely to decrease the time in planning if rapid plan models are successfully developed. So up to mid-June this year, there's been a time saving of approximately 42 weeks in the 300 plus plans created with the assistance of Rapid Plan. This has allowed the 1.3 full-time equivalent radiation therapist role to be utilised in other quality improvement and research project work. The main project has been Pioneer, the project that Shelley has presented to you this morning, which has led to more streamlined clinical pathway for some patients requiring palliative treatment. So looking at the clinical pathway for a patient booked for radical radiotherapy, following consultation with their radiation oncologist, patients then book for simulation where a CT image is taken in the treatment position. This data is then transferred to the planning room where a CT image is likely fused with other images such as PET and MRI, and the contouring of the treatment site and organs at risk are done. Clinically acceptable dosimetric plan is then produced and checked, and the patient's ready to start their treatment. So the triaging of patients from consultation to start of treatment is between 3 and 4 weeks, maybe longer, maybe shorter. Where we're currently the consultation with the radiation oncologist and pre-treatment imaging has remained much the same, apart from the Pioneer project, but we're soon to introduce even more automation software that promises to change the landscape of radiation treatment. Rapid plan's already been introduced and has led to huge time savings as well as high quality treatment plans. The Velocity software is soon to be introduced, and it will improve multimodality image fusion and the deformation of images from different sources, as well as enabling automation in the outlining of structures that need to be considered when looking at the distribution of dose within a patient's body. All of this leads to spending less time on tedious tasks. With Mobius, which is a quality assurance software product for checking the quality and deliverability of a patient's treatment plan and treatment machine QA tools, there will be the potential to help improve treatment outcomes for patients. The utilisation of all this automotive software points to a future that will allow many of the steps in the process from consultation to treatment to be eliminated. So looking at the part on the right-hand side, leading to true adaptive radiation therapy. So it's likely that a patient during their initial consultation with their radiation oncologist will be able to view an initial dose distribution plan created from their pre-existing diagnostic images, therefore involving the patient even more in the decision-making process, as well as being able to present the patient with more information on which to base their consent for treatment. For example, when a decision of choice between a high dose to one area compared to another area might be necessary. Following this, all of the processes previously undertaken within the planning space will move to the treatment unit, creating a clinically acceptable dose plan within a few minutes using high-quality imaging and planning software. This process can be repeated daily, therefore adapting to individual tumour and anatomical changes throughout a course of treatment, and achieving this within minutes. We're not there yet, but we're heading this way. Fully adaptive radiation therapy will allow for the adaptation of patient-specific treatment variation that is identified and quantified daily, tailoring more personalised care. More specific targeting can lead to tighter treatment margins and escalation of dose that will lead to decreased toxicity and improve patient outcomes. The current time savings from the utilisation of knowledge-based planning allows for time to be spent on more difficult and challenging cases and has freed up time for RTs to be more involved in collaborative project work with medical physicists, including QA and QI studies. For radiation therapists, the decisions that will need to be made on the treatment unit are currently outside their scope of practice. They'll therefore need to enhance current skills and develop new knowledge and skills in areas such as soft tissue anatomy and matching, plan comparison and patient assessment. Technology continues to advance, and the future looks bright in terms of ongoing development within radiation oncology that will change the role of radiation therapists and radiation oncologists and medical physicists in the treatment of patients, but more importantly, lead to the better outcomes for our patients. Thank you.
Thank you very much. Any questions?
Kelly. Hi, Kelly.
Thanks, John. So with that information and what's a big topic of conversation for radiation therapists is at the moment is someone could look at that information you've presented and say, great, we've decreased the time that radiation therapists need to plan by 42 weeks, and we've decreased the number of therapists that need to be in the department, particularly in the planning.
Yep.
And I take your point that helping ourselves present the aspect of our role that is involved in patient care is the really crucial point here. How do we convince the people in power, for want of a better word, or the people with the dollars that this is actually important, knowing that just presenting information around cost savings doesn't actually get us very far?
Yeah, I guess the fear amongst radiation therapists is that it's going to lead to less radiation therapists actually being needed in a radiation oncology department. And our manager and our group don't see it that way. We see it as an opportunity for radiation therapists to actually take on other roles within the department. So, for example, the initial consultation, there will be a radiation therapist there with the oncologist who will call up the patient's plan or be able to change it at will to show the patient, to be part of patient information and informing patients. RT's being more involved in research and stuff like that. There's still going to be a need and a role for radiation therapists within the planning space anyway. There's always going to be complex and tricky plans. There's always going to be radiation therapists will need planning knowledge, good planning knowledge, because they're going to have to make decisions on the treatment units. So we don't see it as an opportunity for people to get rid of radiation therapists.
Yeah, I know, neither do I. So we have to convince them that.
Yeah, I think you need a manager that is behind it, basically.
Yeah, I think we need to brainstorm more how we move the profession forward.
And we are bringing this up at as many conferences as possible for radiation therapists to have input into where we go as a profession. Yeah.
Yeah, you know you have my support.
Thanks, Kelly. Thank you. Oh.
I was just wondering, is it very popular? Like a lot of people doing this?
Radiation therapy?
Radiation therapy, I hope so. No, the pre-planning, the using of these planning
more
tools.
and more, yeah.
Yeah?
So rapid planners or whatever other product.
And in rural and like in regional areas?
Yes. It takes a long time to get the knowledge and skills to do it, and hopefully these models can actually be used in other departments. So for a rural department, they may be able to use the same models.
Yeah. Fantastic. Yeah. Any other questions?
Lisa.
Lisa, running for the microphone.
These are some of my old students. That's why I know their names, not the...
Hi, John.
Hi, Lisa.
First of all, awesome presentation. And I share Kelly's and your sentiment about radiation therapists being involved more in patient care. So, given that you are very involved in education, who do you think needs to take the lead on upskilling radiation therapists to move more into that space of leading initial consultations or playing a large role, treatment reviews, taking more of the psych-onc types of aspects of patient care on? Is it the professional body, the university, or the workplace?
I think it needs to be both the universities and the professional body, and all of the departments, you know, and people within departments who have a passion for education and research.
So you'll start
it? It's got to be everybody working together. Yeah.
Yeah. Beauty. Anyone here from ASMET? No. Okay.
So yeah, it definitely was brought up at the last ASMET conference, and we're going to be trying to have another meeting with the chiefs at the next ASMET conference as well, because it is a conversation that needs to be continued.
Great work.
Thanks.
The future is changing. That's the theme for today,
Future
isn't
is
it?
changing
It
and
is.
rapidly. Yeah.
And for the better, by the looks of it, for the patient. Absolutely right. Okay, thank you very much.